everyone, and a big thank for you for being here today. I, Amit Saxena, along with my colleague Dr. Deepika Chabra from Medical Services, on behalf of Jagsonpal Pharmaceuticals Limited, Pharma Division would like to extend a warm welcome to this webinar today, organized by SIG Endoscopy of Indian Fertility Society, with academic partner Nayar Division of Jagsonpal Pharma Ltd, makers of EndoReg 2 mg tablet of Divagest, Divagest range of natural micronized progesterone as Divagest 200 mg vaginal soft gel, Divagest SR tablet of 200 mg and 3 mg 100 mg, and injection Divagest 100 mg. Jagsonpal would like to thank the experts and participants for joining us today. Dear attendees, please note this webinar is streaming live on Facebook. The link will be shared on the chat box for you to please share with your friends to be a part of this webinar today. Convener for this today's program is, can I have a slide? Dr. Punita Bhardwaj. Madam is an expert in endoscopy, practicing as unit in charge senior consultant at Sir Gangaram Hospital, New Delhi. The co-convener are Dr. Priya Bhave and Dr. Maansi Jain. Dr. Priya Bhave is Secretary, Indian Fertility Society, MP chapter. She is consultant and head reproductive medicine at Bansal Hospital, Bhopal. And Dr. Maansi Jain, SIG Endoscopy, is consultant reproductive medicine at KJ IVF, New Delhi. Now I request Dr. Punita Bhardwaj ma'am to please start this session.
Good evening, everyone. Sorry for the delay. I now invite, SIG Endoscopy is about getting everyone on board in laparoscopy. Basic idea is to connect with a lot of people who are hesitant in starting endoscopy vis-a-vis fertility, to get them interested from far off corners of India, and to get them on board and get them going. And of course, to set guidelines for correct methodology of practicing endoscopy. I wouldn't take too long, as it is we are running a little late. I invite the chief guest, Dr. Kuldeep Jain, to say a few words. Dr. Kuldeep Jain.
Thank you, Dr. Deep and Dr. Punita. It is really nice to see all activities of SIG Endoscopy under your leadership. So I really want to congratulate you and the whole team, Dr. Priya and Maansi. They are doing wonderful job.
Yes, I think, and you are the mentor and the guide, sir. So I guess it's rubbing off on us.
Yeah, but main work you people are doing. So really, I must congratulate. Whatever I had thought of having activities in SIG, they are all being perfectly planned and executed. So congratulations for that. It is my pleasure to be here joining a chief guest, because this session is looking very special to me. We are having expert Dr. Abha Majumdar, whom you will be conversing. I am looking forward to her conversation, because see, whatever she is one of the stalwart which everyone, all people who are practicing infertility or endoscopic surgery, they are always looking for some pulse of wisdom, and I am sure that today's conversation with her will really benefit a lot of youngsters. So
yes,
that is
that's the idea.
I'm really looking, and this is very good initiative which you have started, speaking to people who have really started from scratch, and then they have attained so much height, and they can always give you everyone some tips to progress and to give best outcome in their practice. So it is really nice. And today's topic is also, because the SIG endoscopy, I think, believing in the focus program, picking out one topic every time, and that is really good see that the discussion is going in right direction. So I am really sure that today's discussion also is going to be very good, informative, and all experts will be delivering a few messages. That is what is required from any program. That few important messages should go uh, uh, after the uh, each program. So they are really helpful in improving the ethical practice. That is what we are looking for. So thank you. And once again, I must congratulate whole team for putting up such a nice effort. Thank you. Thank you very much.
Thank you so much, sir. Hope to see you in the end also. Thank you.
Yeah, I will be there.
Right, sir.
Yeah.
Without further ado, I think I'll invite Dr. Ruma. She's a brilliant girl and a friend and a colleague working with us at Gangaram Hospital. She has lots of academic achievements to her credit, and she has loads of publications. She's a reviewer. She's a teaching faculty guide at the NBE Fellowship in Reproductive Medicine at MIT and IFS Fellowship in Reproductive Medicine. And she's a senior consultant and associate professor at the Center of IVF and Human Reproduction at Sir Gangaram Hospital. And believe me, that center is doing wonderful work since a long time. And it's a hard task to be there. So if she is there, she is brilliant in her own right. Dr. Ruma Satwik.
Do you want me to take over from here?
Yes, please.
Okay. Many thanks, Dr. Punita, for all those kind words. And none of this is possible without my seniors sitting here. I thank you for giving me this opportunity. I have to say it is a challenging talk, and I hope we can make it easy. And as Dr. Kuldeep said, some take-home messages for all of us. So may I invite my panelists, Dr. Himani Aggarwal, who has also been at Gangaram as a DNB student, but currently, and we are happy to see this, is the director, Meerut IVF Test Tube Baby Center, Bardhaman Hospital, Meerut. She has won the Best Graduate Award from, while she was in Sir Gangaram Hospital, and also has various publications in national and international journals to her credit. Dr. Manjusha is a senior consultant at Sahara Hospital, Lucknow, Obs and Gynae. She's the secretary, IFS UPE chapter, executive member, LOGS and AGOI, and has also been the organizing committee member for various bodies. She's the honorary teaching faculty, MRCOG, courses of RCOG, and has important publications, which are, and I would think they're very important, review of 400 maternal deaths at government facility, Delhi, and cesarean audit at a major corporate hospital. I'm sure we have lots to learn from you, Dr. Manjusha. The next panelist is Dr. Vandana Jain. She is Director, Vardhaman Infertility and Endoscopy Center, Muzaffarnagar. And she has been affiliated with different organizations and different centers at different points in time. She's done her fellowship in laparoscopy, the ICOG fellowship in IVF, Austria, New York, Singapore, and she is a member of the AAGL. She's also an executive member of ISAR and a co-opted member of UP chapter IAGE. She has won the contraception quiz and best slogan competition and laparoscopy quiz at AIMS, and has contributed several chapters in laparoscopy and many other textbooks, along with publishing other papers. But we have Dr. Vaishali Tandon, who is an IVF consultant and director of Dr. Kamlesh Tandon Test Tube Baby Center in Agra. And hers is the first center to offer PGS service in IVF in North India. And she's been practicing IVF for the last 20 years. I'm very happy to have all of you on the panel, and hopefully we'll learn from all of you and your experience. I'm going to start sharing my slides here. As we know, today's talk is on adnexal masses and their management in the reproductive aged women. And without sort of going any further into the topic has already been introduced, but just to give you a short introduction on what would constitute the adnexal masses, it could be solid, cystic, or mixed consistency masses arising either in the ovaries or fallopian tubes or both the structures together. And there are these masses that one comes across either in the ovary, which could be simple cysts, endometriomas, benign ovarian tumors, and then borderline and malignant tumors. Or they could involve the fallopian tubes, and these could be seen as clear cysts, paratubal cysts, hydrosalpinx, hematosalpinx, pyosalpinx, or even an ectopic pregnancy, a chronic ectopic pregnancy can present as an adnexal mass. Peritoneal masses that you'd see, which are extra tubo-ovarian, are pseudocysts, appendiceal abscesses, and pelvic kidney masquerading as adnexal masses because they are in the same location by the side of the uterus. So these could confound our diagnosis, but one needs to be aware of these entities. So through this panel, we hope to discuss 4 cases which are commonly encountered. And we will see that these masses have various presentations. So most of the times, adnexal masses may be discovered incidentally and not really because it has presented with mass effect, pain, or an acute kind of picture. It could also present because the woman is having fertility issues, and during workup, this has been found. And otherwise, it could mimic a malignancy, and it has been found because the patient has presented with symptoms of advanced malignancy, and like weight loss, like nausea, gastrointestinal symptoms, and during a workup, one has found adnexal masses. So those are the possible presentations, and one finds that there will be challenges with adnexal masses in a woman of reproductive age. These challenges, and this is what our discussion will be on, are with respect to diagnosis. Because as you saw that the cysts, the masses in the ovaries, in the fallopian tubes could either be you could divide them into something that will be there temporarily and will disappear over a certain length of time, or you have these, they are there, but they are either, you can't decide whether they are benign or they are malignant, that they are there permanently, but you do not know of its malignant potential. So, and very few methods will be precise in diagnosing, that there will be challenges with its diagnosis. Again, if you find it, you're never sure if you could just leave it there, even if it is a benign appearing mass, could you just leave it, or do you follow it up, or do you do a surgery? And then again, the surgery itself may have implications on fertility per se. So one needs, these are the challenges that one comes across, right? So with this, we come to our first case, and this is a case-based discussion. So Dr. Himani, I'm posing this to you.
Yes, ma'am.
This is a 32-year-old lady, and she's been trying for 2 years to have a baby. There are no issues with coitus or her periods. The only issue with her periods is a level of dysmenorrhea, which requires her to take 2 to 3 tablets of NSAIDs per day for about 2 to 3 days. And this has been there for the past 6 months, and it's only been increasing with time. You have worked her up, and her semen analysis, which was done elsewhere, is normal. Now you examine her and you find that her BMI is average 24 kilograms per meter square. There are no signs suggestive of hirsutism, galactoria, acanthosis. There are no scar marks on her abdomen suggesting that there's never been a surgery in the past. And when you examine her, the uterus is retroverted, probably normal size. You can't really make out the size, but in restricted mobility, there's fullness in right adnexa, and there's tenderness on deep palpation. Now, this is the picture. on ultrasound, and you find that this is, would you like to describe this mass, Dr. Himani? What does it look like to you?
Ma'am, it is probably looking like an ovarian endometrioma. The ground glass appearance is typical characteristic.
Right, right. Okay, great. So here, is there anything else you'd like to focus on? So this is basically, I've just brought in the picture of one ovary. Would you like, you'd want to look at other parts of the other organs in the pelvis as well?
Ma'am, as you mentioned, on pelvic examination, the uterus size is normal, and there's fullness in right fornix, tenderness. So all these are going in favor of endometrioma.
Okay, right. So so basically, this is a unilocular, smooth walled cyst with the ground glass appearance, most likely to be endometrioma. And you can see the size mentioned here is 9 centimeters. That is huge. So would you want to look at any other differential diagnosis, or this is certain?
And there's adnexal tenderness. Then we can also think of ectopic pregnancy, though the ultrasound picture is clearly of ovarian endometrioma.
Right. So in this case, perhaps you kind of are reasonably certain based on the patient's age, history, examination, and ultrasound that this is ovarian endometrioma. What would you want to do in such a case? Now, she has primarily the issue of infertility. Dysmenorrhea is also an issue, but not her primary complaint. She came to you with being unable to conceive.
Go for basic hematological biochemical markers, and then we'll decide for surgical excision.
Okay, so basically, between the three, between expectant management and surgery or medical management, you want to go in for surgery in this case, right?
Yes,
so
ma'am.
what are the points that have helped you in deciding in favor of surgical intervention?
The most favorable feature for surgical management.
I think, lost you in between. I couldn't hear the first statement you made.
Ma'am, as the size is quite big, it is 9 centimeters, more than 4 centimeters. So I would go for laparoscopic surgical excision.
Right, right. All right, that makes sense. So any advantages that you can think of surgery over let's say starting medical management? So this is a clear case. This is something with a 9 centimeter endometrioma. So something that large is definitely altering what is known as the functional capability of the fallopian tubes to function. Probably it's hampering ovulation, and by causing a reduction in that size, and we'll come to what methods to use to do that. You will improve her surgery. You will improve her factors for fertility. So let's say this endometrioma was not 9 centimeters and it was 4 centimeters. I'm just posing it back again to Dr. Vandana Jain. What would your management have been in this woman?
So first of all, I would like to add, ma'am, in the DD also, when we have a mass as big as 9 centimeter, even with the same appearance in our OPD also, we've seen a lot of patients with combined presentation. Sometimes it comes out to be a mucinous on one side and multiple small endocyst on the other side. So for a big mass, we should do a complete tumor marker test and definitely rule out with an ultrasound. Then, as you mentioned, in management, in 4 centimeter, suppose if it is unilateral, 4 centimeter, we would counsel the patient, because as per the guidelines for a 3 or 4 centimeters, sometimes they give an advice, okay, fine, you can go to counsel the patient for IUI or an IVF. But we need to counsel the patient correctly. For example, if I take her for IVF, it might be difficult. And if she has small cyst on the other side also, it is very difficult to do a pickup with multiple cysts. As a laparoscopic surgeon, my approach is always do a laparoscopy, do a complete clearing of the pelvis, remove all endometriomas and do a complete peritoneal clearing, and then take the patient immediately for IVF. Right. Because in ovarian endometriomas, the ovarian reserve also gets exhausted very fast.
Right. let's say with a 4-centimeter cyst, this lady had the entire picture that was shown in the case history.
Okay.
But there was azoospermia and you had to plan an IVF on account of that, or let's say severe oligoasthenozoospermia.
Hmm.
What would you do with the 4-centimeter cyst?
So fine, ma'am, I would do a detailed counseling of the patient. If she has a male factor also, I would tell her that she can straight away also go for an IVF. I would stimulate the patient. The size of endometrioma might increase. And there is a minimal, we always try to avoid, whenever I do get patients of repeat, suppose I've already operated and the patient has a recurrence and doesn't want to go for a surgery again. So what we do is we do the pickup on the other side, remove all the eggs on the other side, and then go carefully through the endometrioma affected ovary, avoiding the endometrioma as much as possible. But you know, ma'am, with all these endometriomas, if it is patient has never got operated, my first choice would be always to counsel the patient that a surgery is better if it is more than 4 centimeter, because you always have those small jellies and everything around, which sometimes when you start stimulating them, you do get a lot of other small endometriomas and jellies.
Right. So I think we've already discussed this patient counseling prior to surgery and what is the purpose of this surgery. Dr. Manjusha, would you like to take this?
Yeah, thank you so much, Ruma. Very engrossing discussions going on. This was exactly this. It's very important, you know, because we got about the counseling prior to surgery. We got to be able to tell the patient that the surgery is one thing not going to guarantee her to get pregnant. We got to explain to her that endometriosis is not just a disease which is affecting the tuber-ovarian relationship. So clearing the endometriosis does not mean that she's going to come back pregnant. So she got to understand that. One more thing I would like to do an AMX again before I take her for the surgery, so that more for the medical legal importance, so that I can tell her that, look, this was your status before we took you out. The purpose of the surgery, of course, is to reduce the load of the endometriosis present within her, so that it could, you know, improve the tuber-ovarian relationship, reduce the inflammatory cytokines available there, maybe improve the implantations like that. And then, of course, it will make pickup easier if the large mass is not there. So this is the important thing of this surgery. One thing I would like to bring up, which Vandana said, that she said that she would like to go for IVF. So here we may or may not go for IVF right away. We have to consider the patient's affording status, what she is for, and how eager is she. 2 or 3 cycles of IUI with ovarian induction may be tried, in my personal opinion.
Right, right. So let's say one had to sum this up, the counseling, and so this has already been said by the panelists. The counseling is to inform the patient of what they should be expecting from the surgery. Because of the adhesiolysis, because of the mass reduction, there is likely to be a reduction in pain. There could be a fertility improvement in spontaneous cycle if the clearance has been very good. And if you're planning IVF, then a surgery such as this, something with the 9 centimeter endometrioma, would lead to improved accessibility to follicles. It might also, because there is so much of endometriosis, there are adhesions, you might also be able to identify perhaps adenomyoma and address that through a surgery, but only large adenomyomas are addressed through surgeries, not small ones, so which should improve the implantation potential in IVF cycles. And if you find a lot of adhesions and you've been able to identify hydrosalpinx also in during ultrasound scanning, then there could be a possibility of tubal clipping in a case of distal tubal disease with severe endometriosis. This is only in the presence of hydrosalpinx, not without it. Possibility of ovarian reserve reduction because you will be performing a cystectomy, possibility of recurrence despite clearance. And so all of this is prior planning. Prior planning also includes anticipating case difficulty and bringing in, perhaps if one can manage it on their own, it's fine, but maybe seeking help at the right time. This is preoperatively informing the person to come and help you out. Here, of course, it has already been said, laparoscopy is preferred over laparotomy, right? So now the same individual went through a laparoscopy, and in the first sort of view here is I couldn't get the whole endometrioma because it was captured at a time when it had already been ruptured. So it showed not just one, but bilateral multiloculated endometrioma, 9 and 4 centimeters. The POD was obliterated. The tubes and distal tubal ends were not identified. Now, Dr. Vaishali, would you like to take this question? Tips for performing a good surgery to optimize pain and fertility outcomes. Now,
would be fertility enhancing surgery.
yes.
Because endometriosis pain surgery will need extensive dissection, right? So my focus would be more in preserving the ovarian tissue, conservative surgery. So only draining the endometriomas and cauterizing the peritoneal implants, the pouch of Douglas, that much is okay. But removing the cyst wall and cauterizing the cyst wall, we don't do from many years. And just to add on, before we do a surgery with such big endometrioma, conservative treatment like IUIs or natural conception, waiting for that, it usually doesn't help. So down-regulating the patient before menses and then taking her for surgery in the next cycle, and then further maintaining down-regulation for 3 to 4 cycles, maybe for maintaining amenorrhea of 3 to 4 months, followed by IVF ET would be the best option available, I think, for her. Because she is already 32 years and her AMH must be borderline. Along with such big endometriomas, the AMH will further fall down. So going in for IVF cycle in her case would be the best. As much ovarian tissue we can preserve as much as possible.
Right. Right.
Yeah.
Thank you, Dr. Vandana. Dr. Vaishali. Dr. Vandana, would you like to take this question on?
Yeah, so first of all, I want to just clarify.
Protect.
Whenever I take a patient for endometriosis, we do not take the patient for IVF immediately after. We definitely take the patient for 2 to 3 cycles of IUI, or a little, or if the patient's age is less and the endometriosis was not grateful, we allow the patient 1 or 2 natural cycles also. And second thing, only if there is a severe male factor or another indication for IVF, or the patient, it's the repeat surgery of the patient, that is the only indication where we take the patient for IVF straight away. Then the second thing, in case of surgery for endometriosis, what I would like to say is that we always begin, the most important thing is that you have to use minimal cautery on the ovarian surface. We do not drain the endometrioma directly. We always start from lateral pelvic wall. We start clearing from the lateral pelvic wall, put a uterine manipulator and a rectal probe so that we get enough traction and counter traction. We lift the ovary above the pelvis. We do not drain it directly. First, we clear the pelvis, because if you drain it directly, there would be chocolate everywhere and the rest of the clearing would be inhibited. So we lift the ovary above and then we clear out the tissues and the tube. Also, one more thing, very important thing I would like to add, the tubes in endometriosis are very good. It's not hydrosalpinx, it's mostly hematosalpinx. They may be thickened, but if you do a very good clearing, we have seen the patients conceive. If the male factor is good, age is good, they do conceive. So usually we do not require tubal clipping also if the endometriosis is not very severe. So we lift the ovary above and you have to identify the right planes. If you lift the ovary in the right plane, you would not encounter bleeding. So there would be minimal use of cautery, and if there is minimal use of cautery, there will be minimal loss of ovarian reserve. So clearing, maintain the tubo-ovarian relationship, do salpingo-ovariolysis, release the tube, do lateral pelvic wall dissection, clear the round ligament, clear the pouch of Douglas. After that, you drain the endometrioma and then identify the right plane. Now, there are many techniques described to do a cystectomy in case of endometrioma. One is you drain the endometrioma, identify the capsule of the cyst and the cortex, give a clean cut, and then strip the lining with the help of traction and counter traction. The other method is we can do hydrodissection. We can infiltrate diluted pitocin in very minimal amounts, or just a normal saline in between the cortex of the ovary and the capsule of the cyst. And then the cyst pops out on its own. So that way you do not use cautery. Only if the cyst lining is very big, at the end, to separate the cyst lining from the ovary, you might have to use cautery. And then after clearing, a very good suction irrigation is very important to prevent any future adhesions.
Right. Thank you, Dr. Vandana, spoken like a true professional and someone who does this on a routine basis. So yes, adhesions and adhesiolysis is essential. You don't just drain the cyst and leave it there. The idea is to prevent an early recurrence and also to relieve the woman from her pain. What you want to do all of this simultaneously, because she may, I mean, your treatment might not be successful, your infertility treatment, but at least she should go back with some relief in her pain, relief in, those mass effects, and the adhesiolysis has to be complete as possible as one can make it. What adhesiolysis will also accomplish is it will identify perhaps areas. So in a case like this, we found that after draining that cyst, there was another one right behind it, which we wouldn't have been able to identify if we hadn't mobilized the Adnexal, the entire TO mass. So this is a TO mass. All of it was buried under adhesions. No, absolutely no planes could be made out. It was only after draining cyst 1 and after lysing the adhesions, where you can see the Adnexal is stuck to the posterior surface of the ovary. And once we lift this, another cyst was found right behind it. So what, it'll just show up in a bit. So what a complete adhesiolysis will also do is it'll identify other points which would have otherwise been the cause for her pain. It would allow you to identify the anatomy of the tube. In a case like this, there was fimbrial agglutination in the end. There was complete tubal occlusion. So, of course, we also had to do, and imagine in such a case, if a second surgery, so this is the second cyst, you can see it. This is the second cyst, which is now showing up, and it will be drained and it will then be lysed. So when you've identified the cysts, you've drained them, the idea is to do a cystectomy and not just leave them there. So remove the cyst wall as much as possible. This prevents early recurrence. And if you need to use electrosurgical current, if you need to use energy, then use harmonic or monopolar, and harmonic or bipolar more than monopolar. So I think we'll move on to the next thing. So both sides, the thing was drained, and we then move on to the.
Dr. Ruma, do you suggest cyst wall removal in such a patient at this age with such big endometriomas?
Yeah, so she
because the cyst wall will remove most of the ovarian tissue.
In a case such as this, you would need to give her some relief from her pain and such a huge endometrioma. You also need to biopsy the cyst wall. If you just drain and fulgurate, it is not going to help much. So
no, if we down-regulate her for next 3-4 months.
That's still not going to help, but let's take other opinions. Dr. Manjusha, what do you feel? Would you prefer to do fulguration?
I know this is
as much as I can, and only at the basis when the removal is a little difficult, say 2 or 3 points, I would use electrocautery, diathermy, bipolar one. Only at minimal use of that I would do. And just draining the cyst and leaving it behind would really increase the possibility of residual and recurrent disease and give her the misery of pain again. So definitely I'm not in for drainage and leaving it like that, even for a cyst this big.
Right. So finally, we come to post-operative fertility management. What would be the role of GnRH agonist in a case such as this? Would you give GnRH agonist or no? Do you want to take this? Dr. Himani, can you hear me?
Yes, ma'am. For the initial few months, I will give GnRH agonist. It will inhibit the activity of any residual disease. It will suppress ovulation. And if in case there is some peritoneal spillage and all, then it will also reduce the adverse effects due to that.
Okay, any other opinions on this? Dr.
Ma'am, yeah, so ma'am, we have this limb of study going out also at our center. We have two groups of patients. So usually if it's a repeat surgery, as I mentioned, or it's a recurrence, we do not give GnRH agonist and we straight away take the patient for IVF. In patients who are wanting to conceive normally, we might give one dose, but we do not prefer it. We like the patient to try from the next cycle itself.
So let's divide this into two questions. Let's say your surgical clearance was perfect. At the end of the surgery, you were able to restore TO relationship, and you found that the tubes are patent and the fimbria look perfect. They might be, the tubes were swollen, but the fimbria look perfect in architecture. Now, what is your plan? Do you want to give GnRH agonist? Would that
No,
help?
ma'am. No.
No, ma'am.
It would not, right? So the other question is, let's say this, well, you couldn't do a complete clearance. You've managed to drain, excise the cyst wall or fulgurate, as one of the panelists said. You've managed to do as much adhesiolysis as was possible. But at the end of it, you made an assessment based on what you have done, and you feel that the prognosis for spontaneous conception is poor. Now, what are you going to do?
Frankly, ma'am, I haven't seen a case where we have to leave the cyst wall. So I really don't know about this, because it is always easily possible to identify the cyst wall. Only if it is 1 centimeter, maybe then you can't. But if it is 2, 3, 4, 5 centimeter, there is not a chance.
Right. Dr. Vandana, I get that. The question is, would you give GnRH agonist in a woman whose prognosis for spontaneous fertility is low after a surgery?
Yes, then I would like to.
What will the purpose be?
To suppress the disease, and then you can take her for IVF, because
Does
long
it
cycles.
improve fertility? That's the question. Does it improve fertility after a surgery?
No. Only suppresses the disease.
Yeah.
So only temporarily.
Only temporarily.
Yeah. The point here is that there are now, of course, guidelines. And so ESHRE 2022 is very categorically recommending against giving GnRH agonist after surgery because it does not improve spontaneous fertility outcomes. If you have had an optimal clearance, you allow spontaneous attempts for 3 to 6 cycles based on female age and other factors. And of course, following optimal clearance, would you do IUI? That's the next question. The answer is maybe, but the evidence is based on a very small retrospective study that IUI might lead to better outcomes. But frankly, I mean, there is good enough logic to assume that spontaneous conceptions after an optimal clearance should have the same kind of pregnancy rates as an IUI. If it has been a suboptimal clearance or there are other factors, then an early IVF is indicated. And if you are going in for IVF, then pre-IVF GnRH agonist is still not necessary because it does not improve IVF outcomes. So those are the take-home points. So after a surgery, if at all, you may have improved something in her. Do not give her GnRH agonist because that is the most fertile period for her, right? So we are not going to go into the EFI. Let's go to case 2. And
can we seek Dr. Abha's opinion on this before we move on, Dr. Ruma?
Ma'am, are you there?
Yeah, I'm there.
Yes.
Listening very.
Yes.
Okay, I think your guidelines are very good. This is what should be practiced. If you've been able to downstage your endometriosis and do a good clearance, absolutely no GnRH agonist, and give the patient a good chance of conception. Make sure she's ovulating. Make sure that they're having intercourse during the time when they really need to. IUI may not help, but if you've downstaged and she's not conceived naturally for 3-4 cycles, adding up COS with IUI is a good option. However, I feel cystectomy is mandatory. Absolutely no indication of draining and fulgurating, that also in a 9 centimeter cyst. And as one of your panelists says, that most of the times we catch hold of the cyst wall. I feel before rupturing the cyst wall, it is good to give an incision with little possibly maybe petricin or saline injected between the ovarian wall, and it separates the cyst very beautifully. You cut over the wall, you separate the cyst as far as possible. At one point it will rupture, then it would be easier to remove the rest of it. Adhesiolysis is a must. And if we've not been able to downstage the disease very well and we are planning for IVF, then it is better to do IVF 2 to 3 months later, because it takes so much time for the ovaries to heal and the ovarian follicles to jump up. Even AMH takes about 3 months after a surgery to come back to its original, or maybe even 6 months. So maybe IVF can be done 2 to 3 months later with or without GnRH agonist. I do not recommend GnRH agonist after surgical clearance in infertile patients who wish to conceive with IVF or without IVF.
Thank you, ma'am. Also wisdom as always.
Uh-huh.
That settles, I think, a lot of controversy. Thank you, ma'am. We move to the next case. Now, this is a 32-year-old lady who's been trying for a year and a half. There is a history of right unruptured ectopic pregnancy, which was managed by salpingostomy 2 years ago. The periods are normal, semen is okay. There are no symptoms suggestive of PID. And everything else seems fine, except that in the pervaginal examination, the uterus is normal size, has restricted mobility, and there's fullness in the right fornix. And this is her ultrasound picture. Dr. Manjusha, would you like to tell us what this might be?
Nod-shaped cystic mass, and it seems to be containing clear fluids, and it is on the site of the uterus, so most likely it looks like a hydrosalpinx. But then thinking widely, it could even be a parafibril cyst, unlikely to be that. Peritoneal cyst, again unlikely to be that. Simple follicular cyst, simple functional cyst, no, again no, because the shape and the size is not suggestive. So my first DD here
would be hydrosalpinx. Also, if you see the contralateral ovary, left ovary, it's behind the uterus and seems adherent. It's not an unusual position for ovary to be. And the right this elongated cyst is also attached to an Adnexal mass on the other side. There is history of ectopic pregnancy on this side, which was managed by salpingostomy. So the question, you've already answered this. Would you like any other tests to confirm diagnosis?
Yes, I would like to do a tubal patency test to look at the status of the other. We could do a hysterosalpingo or a sonosalpingo. Sometimes if the TBS is, if the this is not very confident of if we are under, we may pelvic MRI. Then I would also like to know the status of her ovulatory function before I make up any management decision. The semen parameters, I am not sure if we know the semen parameters.
Do you need a tubal patency test in a case like this? And if at all?
The contralateral tube, I would like to know what it is like, because it would affect my management decision.
Is there any possibility of a flare-up or a PID in a case such as this, if you were to do an HSG? Between HSG and laparoscopy, what would you choose?
See, a lot would depend upon the availability in different scenarios, the attitude of the patient. If all is available and if the patient agrees for a surgery upfront, definitely a laparoscopic evaluation would be better, because it gives us a chance of collective procedure being done in the same sitting. But then if we want the patient to be able to think of and decide as to what she's going to be in for, then definitely we may consider an HSG or a sonosalpingo also. I know I'm putting up a controversial remark here.
Right. I think we will. So these could be the possible. Of course, it looks like a hydrosalpinx, but I mean, do you think it could be a post-ectopic? I mean, these are the points in favor. It could be infective, it could be tubercular. Could it be malignancy, the way it is attached to that mass, the solid mass on the right side? Some tests one would need CBC, ESR, Montus,
Yes, of course. We got to rule out tuberculosis.
and
Yes.
maybe tumor markers if that thing has entered our heads, that it could be malignancy. There's a solid mass attached there. So let's we'll just move on to the next condition. How will you counsel this patient? What consent would you take? Dr. Vaishali, would you like to take this?
Yeah. Primarily counseling will require tubercular tests first, and then if she is if she shows some kind of infection, then treat the infection beforehand. Maybe it may take 2 months time if she comes out to be positive for tuberculosis, followed by HSG. I will, though it's a controversial test, but before counseling, before going in for a surgery, we have to counsel the patient about the contralateral tube as well. Because if the appearance shows that the contralateral tube can show a lead pipe appearance, if it is blocked, and then if we look towards clipping the tube or doing a salpingectomy of the other tube, of the hydrosalpinx tube, then they are concerned with the fertility, married only 2 years with that one ectopic. So husband-wife counseling, and yes, the consent of salpingectomy if required needs to be there. So investigation for about which infective pathology or suspected malignancy, we have to rule out that. Yeah.
Right. So Dr. Vandana, would you like to take this?
Yes. So to me, it appears like a hydrosalpinx or a teomas. So I would like to counsel the patient, since the patient has already tried for so long and her main aim is conception, I would definitely not like to do an HSG in this case. I would like to counsel the patient for a laparoscopy. And for laparoscopy, what are we expecting in a laparoscopy? Since it's already in hydrosalpinx and it contains infective fluid which interferes with their implantation in the normal pregnancy also, I would like to counsel that I would like to remove the tube, this particular tube, and I would like to assess the other tube. Since the other tube is not, there is no obvious deformity detected on ultrasound in the other tube, but there might be a blockage, there might be adhesiolysis, the tube might not be good, there might be a lead pipe appearance, the tube might be firm, thick, not functioning. Though we would only do a adhesiolysis and remove only the hydrosalpingeal tube, we would not remove the hydrosalpingeal tube, but she might need, if the other tube is not functioning well and the other ovary is also adherent, we would like to do an adhesiolysis, clear the pelvis, remove this tube and take the patient for, in future, if required, IVF.
Right.
Why not clipping him? Why
Clipping.
not?
So see, if we do not do clipping in our cases, what we do, if it is possible to separate the ovary from the tube, do a good adhesiolysis, do not damage the ovary, just remove the tube. Clipping is a halfway method. We do not support clipping in most of the cases. Only when it is a very rare case where it is not possible to separate the tube from the ovary and we can see a proximal segment of the tube, only rarely in those cases we do clipping.
But
then the blood supply of the ovary, it will be affected. In such patients, there is already PID. The ovarian reserve, because of the disease, will be definitely affected. And we are going to separate the other ovary also, which is adherent posteriorly. So blood supply is of the ovary is going to be hampered. So doing a salpingectomy, is going to affect the ovarian blood supply.
So again, it depends on the skill. In a tubal removal, what we have to do is we have to remove and remain very, very close to the tube. If you remain very, very close to the tube, spare the peritoneum in between the tube and the ovary, you're not going to hamper the blood supply. Also, if it is a hydrosalpinx, it is always better to remove the tube.
Okay, so I think we've covered this, but this is what we have, that if you were to find a patient with hydrosalpinx and a picture such as that with a history that suggests that this could be hydrosalpinx, we of course want to inform the patient that this is affecting not just your gamete transport and transport of the fertilized ovum back into the uterus. It is also preventing the implantation of the embryo into the uterus. The implantation theory works through maybe a mechanical barrier that this fluid is posing, or it is through other factors, other molecular factors, which could affect implantation. So the idea that there is some such thing, and that it needs, if you leave it be, the chance of spontaneous fertility is low. Not only that, we don't know what the status of the other tube is. It is very likely that the function of the other tube is affected as well. So this needs assessment. This needs to be looked at. One needs to see if hydrosalpinx or whatever is causing it can be corrected or not, which can only be done through a laparoscopy. So clearly, you're not going to wait. You're going to counsel the patient that this is needed. But the patient understands that because the surgery is being undertaken, I will have a baby soon after. You also have to inform her of realistic expectations from the surgery. So a lot of this is decided intraoperatively as to what the status of the tubes are, how severe the distal disease is, whether it can be corrected or not. And if it cannot be corrected, you don't just leave it be, you have to take some action. You have to either remove the tube or undertake what is known as a proximal tubal occlusion, also known as tubal clipping. So if one has to kind of, there is this table that has been made for easy reference, that if there's mild distal disease, along with hydrosalpinx, which would be defined as limited filmy adnexal adhesions, mild dilated tubes with thin and pliable walls, partial fimbrial agglutination, but with lush endosalpinx with preservation of mucosal folds, this would be probably mild distal disease. You could maybe attempt a fimbrioplasty, which is fimbrial dilatation and eversion of the fimbriae back onto the serosa of the fallopian tube. Or you could simultaneously, you could also do a salpingolysis, which is lysis of peritubal adhesions, so that it attains better motility and mobility and its ability to pick up the egg. So if you were doing this, there are different kind of outcomes, and these are reports from pre-2000s, but over 12 months, spontaneous pregnancy rates in mild distal disease after a laparoscopic surgery is about 25 to 50%, and ectopic pregnancy rates are 4 to 8%, right? Now, contrast this with dense peritube, with the severe distal disease, which would be classified as dense peritubal adhesions, gross hydrosalpinx, loss of fimbrial architecture, loss of mucosal folds. Now, with this, the charts of spontaneous pregnancies have been described as after a laparoscopy and after full correction also as between 0 and 20%. Now that could vary, and as Dr. Vandana said, it could be skill dependent, but on an average, one would assume that a correction in this phase is also likely to lead to a repeat hydrosalpinx development. Would you then undertake a second laparoscopy is also a question that one has to bear in mind. So with severe distal disease and some of these, one or more of these features present, perhaps a tubal occlusion or salpingectomy is advisable. And both of them have the same take-home baby rates, or what you would call a clinical pregnancy rate. One is not better than the other. So I think one compromise between what was being discussed is that perhaps a salpingectomy, which is very close to the tube and away from the mesosalpinx, leaving the blood supply intact, if you can do it easily without, spending too much time on it. But if you cannot, because everything is so badly adherent, then at least try to identify the proximal end of the tube and fully identify it. Try not to cut the ovarian ligament, broad ligament. Once you've identified it, a proximal tubal occlusion is as good as a salpingectomy in terms of pregnancy rates.
Dr. Ruma, I would just like to add. So this clipping, as mentioned, so sometimes you do see a patient in ultrasound, you will see collection, peritoneal collections. And when you put a first port only, you see it's a completely frozen pelvis, or there is a collection and the peritoneal collection. In those cases where it is not possible, everything is there. And in those cases, you go and try to identify the tubes and then do clipping, because it is difficult to do a salpingectomy in those cases.
Right, right. Okay, we agree on that. Thank you. So,
Ruma, that will be the last case, I think. It's already 7:30. Dr. Abha would be waiting, so I guess. Hello.
do you want this case or should I end this here?
No, we will finish with this case.
Okay, okay. So now this is a simple appearing cyst, 5 centimeters, which was seen in a woman who's infertile, who's 38 years old and has received oral ovulogens in the past. And it has been there for the past 3 months, right? Although you can see, I would like to ask Dr. Manjusha if what her management for this case would be. Would you like to wait further, give oral contraceptives, or would like to do a surgery in this case?
She's 38, quite an age. She's a lady married one. She's only been trying for a year, but definitely 38 is not an age where I would like to procrastinate. She already has a low reserve. So I would not really like to keep waiting and suppress and trying again. For her, I would like to be more aggressive.
Sorry, did you say suppression with OCPs?
No, I'm saying that at the age of 38, low reserve, I would not like to procrastinate. No, not the OCPs for her. I would like to be aggressive with the treatment. Because a cyst this size would be making even the follicular studies difficult. So we got to be doing something with her.
So you want to remove it. Any chance of malignancy in this, Dr. Vandana?
So it is clearly mentioned she received ovulogens and it is a clear cyst. There is no septae, no multiloculi, vascularity is minimal, no excrescences, there would be no ascites, no history. So this does not appear to be malignant. Only thing that bothers it has been there for 3 months. So you would like to counsel the patient. See, it has been there for 3 months. It has been 5 centimeters. You can have an option of waiting 1 or 2 months. We can try with OCs. But if it does not go, there is always a risk of torsion, or it can be something else. In that case, I would like to do other tumor marker tests, etc., to rule out it is not something else. Because usually these cysts disappear. In few months, they should have gone.
Right, right. She has not received OCP,
not received.
Right. So maybe that is one option as
one
well.
option we can do.
Unlikely to be malignant, and this is what I want everyone to see. There is some. Yeah, ultrasound is a good imaging technology, at least mode to understand whether it's benign or malignant, and there could be suspicion of malignant if it has these features: irregular solid tumor, presence of ascites more than equal to 4 papillary excrescences, irregular multilocular tumor more than 10, and strong blood flow color Doppler. Any one would mean it is veering towards malignancy, but any one of these is still, and so this is the simplest as possible. It is possible to, of course, give her OCPs at this point. And if you think that there are other things that need assessment, like perhaps tubes, or her ovarian reserve is good, you want to then remove it and then go ahead and plan a pregnancy either through spontaneous conception cycles or through IUI COS cycles, right? So just one last thing I want, just this thing to go across as well. We are going to quickly cover this. So this is a 37-year-old lady who's been married for 6 months, who has presented with nausea, complaints of nausea, lower quadrant pain, short period frequency, and light to heavy persistent bleeding of 2 months. Examination is all well, but there is an abdominopelvic mass palpable of about 6 centimeters above the symphysis, and PV confirms this finding. The mass is non-tender, rectal mucosa is normal, right? So here, what are the features that suggest that this could be malignant? Dr. Vandana?
Well, it is a multiloculated cyst. Then I can see excrescences, and then the size is very big.
Yeah. So
Yeah,
that's
and it has papillary structures, as you can see.
yeah.
So all these go in a favor of malignancy, but definitely I would like to conduct my investigations.
Yes.
And blood flow is not mentioned.
Yeah. So blood flow was it does mention it here. I thought I had mentioned it here.
So there are a lot of, so there in the IOTA index, there are a lot of M rules features which are already present there. So I would like to do a complete tumor marker test, and then I would like to counsel her.
Right. What would the role of MRI and biomarkers be in this, Dr. Vaishali?
See, MRI can suggest the origin, the secondaries, if at all there are minimal ascites, and yes, definitely liver and other implants. But ultrasound gives a better, MRI can be only be supplementary to ultrasound and the color Doppler. It cannot be decisive investigation.
So if there is an issue with ultrasound and it's not able to particularly decide if this is malignant or benign, and there's a term used for it, indeterminate, we use MRIs to try and classify it as benign or malignant. And so this MRI, addition of MRI in such a case where ultrasound is unable to make the diagnosis, reduces the risk of misdiagnosing a benign mass. So in this case, it is clear, perhaps an MRI, you could just move into the next level, which is, I'm just skipping all this, which is so that you would want to perform a staging surgery. The staging surgery, how would you want to do this, Dr. Himani? Dr. Himani, are you still there?
Ruma, we can't see her picture on the screen. Her name is not visible on the screen.
Okay, then Dr. Manjusha, would you like to take this?
Yeah, of course. See, in our setup, we involve an oncologist at this stage itself. We would like to, what we actually do is that the oncologist and the gynecologist and the person who has done the scan, we sit together and we look at the details about the extent of the disease and things like that on screen itself. Then, of course, we do all these tumor markers to help us have an idea about what things could be. And it is after that that we sit down with the patient, explain to her that these are the chances. See, she looks malignant, but I'm not sure whether or not she is. So in the suspicion of malignancy, we would, take her up for a surgery, take a consent as if she could be malignant, and then what all we remove. But if we are lucky, it comes out to be non-malignant, and then we could be more conservative about it. So when we take her up for surgery, we take a surgery for malignancy also. And then in our setup, of course, we do a frozen section and then proceed accordingly. One more thing is, should we consider fertility conservation? Oocyte preservation before we take her up for surgery? I think we can consider that before we take her up. This I would like to know from the others.
Yeah, so just the take home from this slide is that if you clearly know through an ultrasound, which you have used your IOTA scoring, that this is likely to be malignant, you refer straight to the gynecologic oncology department, because outcomes for patient are best if these guys are doing it, right? If it is clearly benign, then we as gynecologists can do this procedure laparoscopically and try and remove the cyst or whatever it is, but only if we know that this is clearly benign. Our case doesn't appear that, our case appears that. At this point, I'd like to involve the oncologist. If it was indeterminate, something in between, it has both benign and malignant features, then what are your biomarkers telling you? If your biomarkers are low risk results, it may still be performed by a gynecologist, but if it is high risk, then you definitely want these guys to take over from you, right? So this is important because this has implications in patient survival. So I think we will end this here. Thank you all for this session. I'm going to stop sharing my slides. And many thanks for patiently being there. Really sorry, ma'am, for making you wait much longer than you were supposed to. Thank you. Thank you all.
Thank you so much, Ruma. I think that was fantastic. Wish we had more time to discuss every detail. And thanks a lot, considering that you're traveling tomorrow early morning. She's going to France, guys, and she made that effort. Kudos to her and lots of claps. Thank you so much, Ruma. That was brilliant. Thank you, all the panelists. And I think you all were very good in your own right, and Ruma conducted it beautifully. We go on to the next session. Well, Madam, what to say about her? She is the Director, Center of IVF and Human Reproduction at Gangaram Hospital, and she's brilliant at it. I think if I start reading everything, it's going to be taking away all the time. She's got the President's Medal. She is responsible for the first IVF baby born in North India. She was awarded from the DMA on BC Roy's birthday, Outstanding Contribution to Medicine. She's had a Lifetime Medical Excellence Award, Obs and Gynae by Hippocrates Foundation 2014. She's had the Abdul Kalam Gold Medal in 2015 and Rashtriya Gaurav Gold Medal Award in 2017 by Global Economic Progress and Research Association. She's a Distinguished Teacher of Excellence Award by PG Medical Education by ANBAI and NBE 2017. She was Icon of IVF of North India. I think it's a hat trick, isn't it, ma'am?
Yeah.
She was consecutive years. She's been at it for 3 consecutive years. She's got the Best Integrated National Team of IVF and Most Coveted Award as the National IVF Champion of the Year 2019. And she's a course director for postdoctoral fellowship in reproductive medicine by NBE since 2007. So do you wake up to this achiever? That's Dr. Abha, much accomplished, much celebrated. It's always a pleasure interacting with you, madam. Your zeal, your organized approach, and your grasp of the subject is exemplary. Tell us something about your journey. Your younger days, where did you start your MBBS from? And, you know,
Oh my goodness. Oh my goodness. Well, I did have a little difficult childhood, but a very happy childhood too. I lost my father at the age of 11 and a half. And we were 3 sisters and 1 brother who was just 3.5-year old. So my mother was a non-working mother, and we had no way but to go back to the ancestral house of my father, which is a 3rd-tier city of Uttar Pradesh, Farrukhabad. And I studied in a school called Kanodia Balika Vidyalaya. And then
doesn't matter where you come from.
Yeah. And then I went to do my 9th, 10th, 11th, 12th from the only school which had science as a subject, and they allowed girls to come there. It was probably a girls' school. So I did my 12th from there. We used to have no teachers for 6 months. We used to sit on mats on the floor. And well, that is history now. But but then physics became difficult for me in those days. Now physics is absolutely difficult, very, very difficult today. But in those days also the concept of television and the rays going into television was difficult for us to understand. So I had a person who tutored me for 20 days. He was Professor N.P. Singh. I still remember him very fondly. My mother used to be very angry that he's supposed to teach for 1 hour and he comes and he goes away in 30-40 minutes. So she used to say that he's not giving his full due. Well, later on, when he was asked, he said, oh, she understands what I have to explain, so I don't need to stay any longer.
So it started.
I did my PMT, got selected in Agra. Then my journey started there. Agra was easy. I did need a scholarship from a charitable trust to do my studies. At that time, the scholarship used to be 100 rupees a month. My expense was 125 rupees. So 25 rupees my mother used to give me. But she had 3 more children to feed, you know. I mean, my elder sister and a younger sister and a brother. and she was not working and there was no source of income. So this was, but we enjoyed every minute. We used to love each other. We used to assist each other. And I used to, I was like the delicate one doing drawings, paintings, decorating my house, because my mother lived in really good conditions till my dad was alive. But then he was gone. There was no earning member. There was no money which he kept for anyone. He never thought he'll go as early as at 50 years of age. So it was. Anyways, medical college was, it was frightening for me to start with. I got selected in Lady Harding's, but Delhi used to frighten me so much, being a very timid UP girl. So I never came to Lady Harding's. Then they had only one seat for a non-Delhiite student. And my name was there because in 12th class, I topped the UP district.
Wow.
So the marks were good.
Lovely. Yeah.
Anyway,
the brain behind it was good.
Yeah. And then you know what happened? Because I was used to learning on my own, never had tutors. So MBBS never appeared very difficult to me. And well, by the end of it, I was known by my whole batch because I sort of went on topping after the first professional, every profession.
Wow.
And at the end, there were so many medals I got that the chancellor who had come to give, Karan Singh ji, he said, don't go up the stage. I was very, very thin, maybe 42, 43 kgs. He said, stand on the stage. You're losing a lot of calories going down and coming up.
Yeah, my God, it wasn't easy. It wasn't easy at all. It gave me goosebumps just listening to it. I can imagine what you must be doing.
And I had no one there who came there on my convocation because my mother could not have traveled. It was expensive to come from Farrukhabad to Agra. So my younger sister who studied in Agra College, she was doing her MSc. She was the one who was there to clap for me. And it was lovely, though. I loved every moment of it. I used to shun my very good friends because I used to think that, they deserve to be first and I am first, so they'll feel bad about me. So one day, the one who topped in the profession, that boy caught hold of me and said, why do you keep running away when you see us coming into the ward? I said, because I think that you felt very bad that, I've got more marks than you. I was so stupid. I was so scared. But then I've grown so much, Punita. When I look back, I see I have grown from where a very timid girl. I should have put up a letter written by a colleague of mine whom I met just about 2-3 months ago, who lives in US. He said, I still remember that timid girl in a white salwar kameez, always trying to go at the back of the class, but
and look at you now,
anyone.
Wow.
Facing anyone, would raise her hand very timidly, half hand up, because she knew that all the others were duffers who were answering and maybe she knew the right answer. One surgery professor gave me 96 out of 100 in a surgical pre-test in 3rd year where surgery was not my subject. And there was so much of furor from everywhere. How could a student get so many marks? And it was like, it was very nice, that journey, and then he didn't know who this girl was and everybody was taking the names of the more popular people. And he said, the name is from A, but I don't remember. So that is my early journey. Let's start my new journey.
Wow. So what brought you to infertility? It was a new subject.
See, I told you that I come from a very respected family, but unfortunately, because of my father's demise, we were like very hand to mouth type of a family. But I give all the credit to my mother, who always wanted all of us to study. And today I did medicine and MS. My younger sister did MSc and she was pursuing her PhD when she got married. Then she went away to USA, did her master's in taxation there. My brother did his engineering from Kharagpur, and he's also absolutely self-made. I just gave 1 year to him to study when he flunked 2 subjects in class 8. So I left my internship from Agra, went and stayed in Farrukhabad, and we used to, our time used to be 3 to 8. We used to study. I used to reach home at 3 o'clock from the district hospital, and I used to teach him. And probably that made his concept so clear that today, like, he is one of the leading scientists and engineer in the US, doing very well. So all of us studied because of my mom. And then anyways, I came back to Delhi. I had gone to Libya in between because my husband also didn't have any financial support from his family, neither did I. And we got an opportunity to go to Middle East. Those days in 1980s, Middle East was like on the height. That just go there, some money, come back so that you can at least start your life. I missed out on doing my senior residency because of this.
Does it matter now?
So I just did a job in railways for 2 years so that we could, sort of be on our own. Had my first child, Gaurav, and then we went away to Libya. But 5 years was enough over there. I told my husband, this is no place for growth. We need to go back. We'll get stagnated because my friends have lived there 40, 45 years. 5 years we were back. 1st February 87, I joined Gangaram, and then Dr. Bhandari, I'll give her a lot of credit. At that time, we used to have just one infertility clinic Thursdays. And she said, would you like to do it? I said, yeah. I had no idea, goddamn idea of what. So all I used to do is a semen analysis in the lab, a postcoital test, and using clomiphene. Ultrasound was just emerging in 87. The follicle monitoring was just starting then. And I had no idea, goddamn, what is this follicle monitoring coming back from Libya? So I went and got all the books, everything to find out what is this. And then I would sit with Deepak Chawla and we would formulate that ultrasound monitoring, which is so popular today all over. We made that chart and we said, let us have on a date-wise thing. So from there we started. 87, I joined. 88, Dr. Kochar joined. And after she joined, she was interested in infertility. And then Dr. Bhandari asked me in 89, do you want to switch over to infertility? IVF is growing all over the world and also in India, because 86, our first baby of India was born, baby Harsha in Bombay. This was 88, 89. And she said, we need to do something in Delhi. Are you ready to go into it? I was a fool. I said, yes, I am ready.
You were not a fool.
And Dr. Kotwani told me, mar jayegi, obstetrician hai, you are leaving obstetrics. I was asked to leave obstetrics, gynecology, and give wholehearted support to developing IVF. We started it in 89, 90, when we hired Dr. Gaur. See, what we did was innovation. What is happening now is competition. Now there is so much competition that you have to go over it. And the only way to go over it is ethical practice. Good ethical scientific practice, not really the fancy practice. We have to be truthful to ourselves and to our patients. At that time, it was innovation. Like laparoscope in, Dr. Kochar used to aspirate a follicle and say, run downstairs to that lab where Dr. Gaur is sitting. Let her identify an egg. And Dr. Gaur was a brilliant scientist from AIIMS who had worked on animal oocytes. She had never seen a human oocyte. So she learned to identify the human oocyte. And we started our lab. We used to make our own culture media because no culture media was available. Dr. Gaur used to make it, and she was brilliant at it. She would triple distill water, use it, make media. Yes, someone asked me when we started IVF and had our first IVF baby in 1991, who taught you IVF? I said, my guru is fertility, sterility, and human reproduction. These two journals were our gurus. We used to sit down, and there were only hard copies at that time, no internet, no Google, no phones. There were no mobile phones also. So that was our guru. We used to learn the protocols. And where did we get our GnRH agonist from? This Dr. Kochar said, Abha, if we have to do IVF, we will use the agonist protocol. You get it from somewhere. And we found out Sukh Sagar, chemist in Bombay. Bombay people were using it. So we started asking Narayan Das to get it for us. We used to get Busserli. We used the long protocol with ease. I remember after the first baby, Next year, we had 5 children. After that, next year, we had 11. And then the numbers went on growing from that. And now our pregnancy rates for last month are almost 68% with a single blastocyst transfer in frozen embryo transfer cycle.
Fantastic. Fantastic. So you just self-taught yourself and equipped yourself to master all aspects of infertility. That is what you're trying to say?
One day, Dr. Kochar sent me to Dr. Sadhna Desai in Mumbai, because Mumbai was a leader in IVF. No, Dr. Hinduja had already created the first baby with Dr. T.C. Anand's help. And Dr. Sadhna Desai was doing, and she was a friend of Dr. Kochar. So she said, you go see how she does the pickups and all. So I was there for 2 days. Lovely experience, very nice person, very good environment. And she would do the pickup and then tell me, बहुत easy लगता है ना, इतना easy होता नहीं है जितना हम जब कर रहे हैं तो लगता है. And those 2 days I saw her doing, and rest was fertility, sterility mainly, and human reproduction a little bit, because those articles were a little high. Fertility, sterility was absolutely for a layman like me. And that was our teaching. We followed the protocols. We did the test. There was no AMH then. There was no antral follicle count. The transvaginal resolution was not so good, but we did have transvaginal ultrasound. That is why we could start IVF.
Right. But there was no tussle about being in a private hospital or a medical college, or the management was supporting, and Dr. Bhandari, of course, was the main.
I think she was the main push. You know, what she told was, you have to leave gynae and obs, which I did mildly, but I couldn't leave everything because surgery is my passion. You know how I love surgery, I only know. Nobody knows me as an endoscopist surgeon, but I think I enjoy most doing endoscopies and hysteroscopies. So I didn't give up my surgery fully. Obstetrics, yes, the general OPD went, the casualty went. I never got anything from these 2 places. But by the time the first IVF baby was born, I was in Gangaram for 5 years. And somehow luck or God's grace, people were coming to me for obstetrics, and I did not give that part up. Those who would come to me directly, and I would take up obstetrics. There was one point of time before IVF, I used to do 5 open hysterectomies a day.
Wow.
With Dr. Kutter coming later and then joining in, and we would do, a lot of open hysterectomies. But then to give up everything was not easy, Punita. You know, to say no, that I will not do anything. So I did give up to some extent, but then I took a second attachment very soon, 92. And over there, I started doing a little surgery, and I was asked, why do you go there to do? I said, what do you do? What do I do in my khali time? I sit in the library for some time. Rest of the time, I'm a surgeon. I'm a gynecologist, obstetrician. I need to do. So I kept doing that a little bit. But then, yes, I was wholehearted devoted to developing infertility. So it was not just IVF. It was infertility as a whole, even endoscopy.
Right. They go hand in hand. They go hand in hand.
I never do a TLH, but I can do all fertility enhancing myomectomies beautifully. And I encourage my whole unit to do that, because when you are treating your own patient endoscopically, then you are always very cautious about how much ovary you are losing, how much uterus you are damaging in a myomectomy or adenomyomectomy. Will this patient be able to withstand a pregnancy till term if you've done a surgery on the uterus? So these are the aims which I think we all need to look for, and not just leave them alone. I'm sure all the endoscopic surgeons are good, but you have to identify
the infertility friends, keep goading them not to disturb too much about the AMH, not to destroy the ovary, leave the myometrium alone, leave the endometrium alone.
Yes.
What were the major hurdles that you overcame, apart from being a pioneer and starting up the specialty? Do you think there was something which you would have done differently, or you would have thought differently retrospectively?
You know what, Punita, somehow, somebody asked me, they wrote a biography and they asked me, do you have any regrets? And I said, none. Because when I look back, I think, I was a person who never needed much, or I never, like, I have no expectations. So whatever came, I was so happy at it that when we had a lab in 2 nursing home rooms, I was happy about it. When we got a lab which was better than that, I'm still happy about it. I'm very proud of my IVF lab. This lab, from the electrical points to everything, me and one of my colleagues, Dr. B.K. Rao, we sat and we designed. And I'm extremely happy about how things happened. Yes, there were hurdles. There were times when I was asked, don't do this, don't do that. I used to be just quiet and move out and continue to do what I thought was right. So all I was what I thought was right.
Right. So the major decisions worked for you, and you just went with the flow and worked your very hard.
I never had any goals in life. Never had any goals. It's very bad to say for a person at my stage.
But my God, look at you, the kind of achievements you made with no goals. Wow.
I only thought that today is a day which I have to do my best. And every day I would strive to do my best. And that is all. Goals kept on appearing and I kept on crossing those goals. They crept up and I did try to do my best that day, and the goal was like sort of crossed. And another goal came up. It came up on its own. I never looked forward. I never looked forward to anything in life. Anything.
Wow. You make it sound like a video game. You make it sound like a video game. Come a block, overcome a block, next block, overcome that block.
Yes, exactly. This is how it has been. So I'm sure there were a lot of hurdles. There were sleepless nights. I'm sure I remember that how I would wake up thinking, how can I leave everything and just get into IVF, which has not succeeded anywhere in North India, not even in AIMS, and they closed down. What will happen? So I did have those nightmarish nights. And then one morning I woke up and my husband said, go ahead and do what your heart is saying. Just don't think ki kya hoga, whether it will work or not. I'm sure things will work. So I don't say there were no hurdles or there were no fears. I'm a very fearful person. I get afraid very easily. I'm very timid, but now I'm not. I feel I'm not so timid.
That's because you overcome so much. You overcome so much.
Exactly.
Right.
Exactly. Yeah. So this is all about it. I feel that everyone should not really, yes, you should have a dream, and it is a daytime dream and not a sleep wala dream. And you should, whatever comes your way on that day, do your best, and you will naturally walk more and more towards your dream. But if you look up very high and you try an elevator there is no elevator to success. There is only a staircase to success. It goes slowly. It took me 40 years to reach here. Started
but what
87.
What a position now. What a position now. Tell me something, Dr. Abha. Did you take any decision, any missed decision that you regret or proved costly to you in your own head up there? Anything that you said no? Right.
I don't think, because when IVF was flourishing a lot of new centers were opening up. I was approached by so many people to leave Gangaram, and I would be made someone very great if I developed their center, and I would be made head of the whole regional area or northern India of the centers. And I'm very happy I did not give in to any of these offers. I think money is a number game. You need money till some point, and we all need that money to live happily, to get what we want and to do things which we like to do. After that, it's all in the bank. All what comes to you, so much money is gone to the bank. Where do we spend that money? Where's the time to spend it? Neither in clothes, nor in jewelry, nor in traveling. If I travel, my work will suffer. If I buy a lot of clothes, where will I wear them? And jewelry, I bought whatever I wish to, but I still feel that money is now a number game, and a time is coming for at least me to do all, I wouldn't say charity. This is not charity at all, but I would want that I do what my responsibility is towards society, that I start seeing patients without charging anything. However, IVF is an expensive technology, so that I do not know what can happen. But a stage in my life has come where I would think that I would want to repay back to the society about how much I got. I mean, it's like so much more than what I have or what I had that I've got. That time to repay the society has come. I am trying to do a lot of things.
Full circle.
Do you know, I opened up a education trust on my mother's name in 2013 when she died. Wow. And now a lot of girls are getting scholarship from that. And for sure, Agra Medical College, I tried tooth and nail for 5 years to include one girl every batch to get the Aggarwal Education Trust. I didn't have the word charitable trust because I got a scholarship from a charitable trust. The word charitable always hurt me. So I used to always hide that I get this scholarship. But I feel if you get it from an education trust, it feels more easy to accept it. So now Agra Medical College, first year, after her first semester exam, there is a committee of 4 people who sit down and look into the girl who is the weakest economically and has done best in the exam. She gets a scholarship for the rest of the 4 years. So every year, a girl is added. And this is like my way of doing something, giving back. And plus other things also. But then, yes, now the time has come. I'm 70 now.
You don't look bit. You look
I'm
the same.
70. I just retired last year in November and was made emeritus consultant.
Congratulations. That the word retired doesn't suit on you, ma'am.
So now the time has come that I need to only give back and not take anything more with me.
You're a self-made person, right, Dr. Abha, what we gather from all this. But tell me one thing, is it necessary to have godfathers and godmothers? Mentors are necessary?
No. No. You see, anyone who asks me, is there a teacher whom you remember very well or have a lot of respect? Yes, there are. But I don't think they were all shaping me during my studies the way it is. But I think I was shaped in a way how I grew up in my family. And that I think maybe was genetic, or that was came up through my family
conditioning
atmosphere and the close-knit family we were. My sister got married after my father's death within 4 years, but then 3 of us were like sitting like this together. I can remember no birthday celebration for me ever. Wow. Except when we 3 were together with my mom, there was one birthday celebration for 3 of us together because we're all November born, 12, 16, 17.
Okay.
With one bottle of Coke and lots of Golgappas between the 3 of us. So, these are such beautiful memories that I don't regret this at all. Now the birthday celebrations are like, wow, but I remember that more fondly than anything which I have now.
I think adversities made you what you are. You just steeled yourself to all the tough situations and you just put your head down and pig-headed through the whole blockage that the people, the environment was creating for you. And just you strode away to your position wherever you are with a lot of hard work and tenacity.
So I think Dr. Bhandari Dr. Bhandari had a very astute eye, I think. Why did she put me with this responsibility? Probably she asked others also, and she asked me and I said, yeah, I'll do it. Like a stupid fool, I did not know what was IVF. I learned, I read, I did everything. But she asked me and I said, yes. So
what are the key
I give marks to her.
Yeah. Knowingly or what are the key points for establishing practice and what are the must-haves?
Must-have is, one is education. Right. You must have the knowledge and use the knowledge pragmatically. You cannot do what someone else is doing and say, oh, it's being done that way, I will also do that. Use your own knowledge pragmatically. What you've read, just apply it into practice. It will work better than what others are doing.
So what brings that clarity of thought? I've attended your lectures, I've attended your talks, I've attended your orations. and you come out so crystal clear. What is the secret behind that clarity?
I wish I knew. I think, I'll tell you small examples. Like we used to always have a thought that we must catch the peritoneum when we open up our incision and take a suture over it. Yes, that is maybe correct. But I thought in laparoscopy, we make holes and we just leave them. We don't close the peritoneum. Then why are we jumping into the abdomen to get over it? If it's not bleeding, you just close it even a centimeter below, it will have no problems.
Right.
Then I see my teachers throwing away arteries, saying, ye kharab ho gaya, ye kharab ho gaya. Yet when they wanted us to hold the needle and pull out, they would say, artery uthao, why not another needle holder? Because needle holder has a metal grip holding capability. So it will have bristles. And if our artery holds the needle, we will make it uneven and it will cut the sutures when we try to hold the sutures with the artery. So, I used to think and I used to do things like Petricin. I started Petricin and now I do it even in open myomectomies. Then I started using...
For Petricin, I think my first Petricin was your patient.
Yeah. And then now I use Petricin in all placenta previas. My colleagues tell me, my juniors tell me, why don't you publish this method? We've not had to give a bottle of blood to any placenta previa. But I give it because I feel once the baby is out, I can give lots of Petricin, stop all the bleeding and suture my uterus back. So it's just this, that you think and you apply it. You think and you apply. It works.
Right. Good. Yeah, it's work for you and it's work for everyone else also.
It will.
What message would you like to give to the youngsters intending to walk your path?
One is no elevators, only a staircase. Knowledge is very important. Acquire knowledge and then work on it. Don't look at others and copy. They may be doing something wrong. You would do something right. And perseverance is very important. Hard work is very important. These are the three mantras: knowledge, perseverance, and hard work.
Wow. Everything put together. And that's Dr. Abha for you. Thanks a lot for sparing your valuable time.
Thank you, Punita, for bringing out all the emotional things from me. And I never knew what to ask.
No, yeah, that I didn't intend to, and I'm sure you can take it up spontaneously. You are no longer that timid girl that was raising her up. And then you can face any situation in life. And these are just questions about being as successful and as progressive as you are in your work capacity and your establishing guidelines. And, you are quite a path breaker considering what you've been through, and you had nothing to work on. And you just started from the beginning, from scratch, so to say, and built yourself. Look at the situation that you're in now, and I'm sure you'll be happy looking back what you did.
Yes.
Without anyone's support, and you just stood there doggedly. And
another milestone in my life was my son doing embryology. I picked him out from biotechnology and sent him. We need very good embryologists in this country for IVF to do well. And once embryology grows, our IVF results will be at par with the whole world.
You are giving us 68%. My God, that's phenomenal. That also you need to publish, madam.
And that with a single embryo transfer. This is not two embryos being transferred anywhere. So
absolutely, yeah.
So,
well, ma'am, thank you so much. Thank you for all the pearls of wisdom, your precious time, and apologies for the delay that we took in starting initially because of the. Thank you so much, ma'am. Have a great evening and good night.
Thank you, Punita, for giving me this opportunity to talk about myself. And
no. It was regarding your journey, how hard you worked to be where you are now. And it inspires people. If it inspires people, see, you started with nothing. There are people saying, "Hamare paas ye nahi hai, ye nahi hai, ye nahi hai." You had nothing, and yet you reached the top of the mountain, and you're still staying there with all your hard work. And who says you're retired? No one will even agree to what you're saying, that you're retired. You're as ever. And thanks a lot.
The forests are dark, dreary, and deep, and we have our promises to keep and miles to go before we sleep. So there's still a long pathway left. Let's see. Okay, thank you. Thank you.
Kind of receive your achievements by and by as you go by. At 70, you are not stopping. I can understand that. Thank you.
I will stop at some time, surely within the next few years.
On your time, ma'am, on your terms, that's okay. And by that time, you'll have achieved much, much more in leaps and bounds. I'm sure.
And
of
I'll
that.
probably continue to teach and continue to see patients, but maybe surgery, I will stop at some time.
Oh, that'll be a loss to the surgery.
No, people like you are there. You are a damn good endoscopic surgeon, and I'm sure you'll do a lot of justice to people who require endoscopy.
For your kind words and the encouragement. Thank you for having, a lot for being there. Thank you.
Okay, Punita, bye-bye. Thanks.
Good night. Deepika?
Good night.
Good night.
Yes, ma'am. Thank you so much. There are a few of our products that I'd just like to bring out to our audience who's attached to today with us. There is this EndoReg, our Divagest 2 mg tablets, which is indigenous API with indigenous formulation. The one manufactured at US FDA approved plant of ours. It has a calendar therapy pack of 14 tablets in a strip. So the patient doesn't really forget and there are less chances of a missed dose. Longest shelf life also of about 3 years. We have Verena Nano Silver Gel, which is a latest silver nanotechnology for pro-healing effect, probably for wound healing that you would require. Helps in re-epithelialization and has the pro-healing effect. Also for episiotomies, post-DNC, and it also works as a good for multiple infections. Just one solution, that is Verena. And our natural micronized progesterone, which is available as Divagest. We have Divagest 200 mg soft gel capsules. Those are vaginal. Then IM use injection Divagest 100 mg injection progesterone. And then we have the SR tablets, which are in 2 strengths, 200 mg and 300 mg. So natural micronized progesterone as Divagest. And we really like to thank all of you, especially the esteemed faculty who were present today, and a really, really inspiring talk that we just heard from Dr. Abha. And thank you so very much for this SIG endoscopy that you have chosen, Jagsonpal, Dr. Punita, ma'am. Thank you.
Thank you, Deepika, for a smooth flow. Thanks a lot.
Bye-bye.